All right, thank you. Now I'd like to introduce Dr. Gail Bolan. Dr. Bolan is the director of the Division of STD Prevention at the Centers for Disease Control and Prevention. It will be an opportunity for committee members to ask questions of the sponsor about the committee's statement of task. So Gail's going to take her seat up at the front. Now, we've sent Gail a number of questions. Gail, Dr. Bolan, if you'd like to start with those questions, that's fine, or if you want to make a statement, that's fine. Yeah, at the bottom there's a button that says speak.
Okay. First of all, I believe all of you have the charge that we provided to the National Academy for what we feel is an important product and a timely product at this unprecedented time of rising STIs in the United States. I don't know if my PowerPoint from the initial kickoff meeting has been shared with people, where I really outlined the issues that we see and challenges of today. So I thought it'd be better in the interest of time, because I really appreciate everyone who has joined us to speak today. I'm really interested in hearing diverse ideas, because I think we need some thinking of how we should be doing things differently. So I'd be happy to start with the first question, Sten, if that works. And people, I don't know if they have them or not, the questions. But the first question is, what would make this report more useful to you and your colleagues? So while this report was sponsored by the Centers for Disease Control, I think that we at CDC recognize that we are not keeping up with these rising tides of STIs, and it really takes a village, and we need more leadership and involvement from sort of our society. So I think our goal is that we really would like to see a broad, rigorous, scientific blueprint for what the sort of state of STDs should look like for the nation. So that can involve all federal agencies, that can involve community partners, that can involve public health partners, that can involve academia and industry. So again, I think we really would like to really sort of refresh the roadmap, and I really do encourage everyone to read the previous Hidden Epidemic from 1997, because I feel like it kind of applies to today, except for some changes. So I think that's sort of the general goal that we have. We really would like to have another blueprint that can speak to a lot of diverse partners to see how we all can work together on this important public health problem. The other question was related to the charge of the committee is quite broad. And are there any areas that you would like to focus on more or less? And I think, as I discussed a little bit on the opening call, for a long time the field of STDs has been very focused at the very top of the health impact pyramid. You know, we focus on individuals, we focus on patients and clients. I call it numerator data. And we're not really looking at the context of what's going on with disease transmission and the lives of people that live behind these cases that we count. So I'm hoping, maybe I'm too ambitious, that we can start moving down the health impact pyramid and having more structural and system level ideas on the table that we can start thinking about so that we can have a better impact. I'm also interested in having a plan that is flexible. We've got 35 STIs now, and just, every, few years something new comes along. We certainly, I think HIV really changed the field, but we've now got evidence of sexual transmission of Ebola. We've got evidence of sexual transmission of Zika. And certainly, I don't think that we want the plan to be addressing all 35, pathogens that are sexually transmitted. But if we could come up with something that's flexible so that the concepts, as we move down the health impact pyramid, are applicable to no matter what the latest pathogen of the day is, so that we can be very flexible in our approaches to not only deal with kind of the core STIs, which we at CDC right now are focusing on, chlamydia, gonorrhea, and syphilis, as well as the Center for Respiratory and Immunization is focusing on HPV, which are very important. We really would like to be able able to not make it so pathogen specific, but really make it sort of STI specific and also in a very holistic, comprehensive way. Because I think when we're dealing with clients, we shouldn't be knocking on the door one day and say, hi, I'm here to talk to you about your exposure to syphilis, and then someone else comes the next day and says, hi, I'd like to talk to you about your exposure to HIV. So how we can get to that sort of more comprehensive, holistic approach for individuals who are vulnerable to acquiring these infections. So that's my turn. So then then you got into the question about pathogens. So the question was about, other than syphilis, gonorrhea, and chlamydia, how much focus are you looking for other STIs? So I think I've tried to address that by saying, I don't think we want to make this specifically a pathogen focused report. We clearly want to look at what we can actually do to improve health impact. Obviously, traditionally, we focused on the treatable STIs, but I do know that, there's a lot of individuals that have a lot of concerns about herpes. A lot of people say CDC is not doing enough about herpes. I would say that we actually do quite a bit about herpes through our treatment guidelines and appropriate sort of health care and counseling and appropriate suppressive therapy or whatever for patients who, a lot of them are very stigmatized by a herpes diagnosis. The next question gets into what are the restrictions, including funding allocations in your agency or division, that will determine your response to the recommendations in the committee's report. I would say that our funding appropriations actually do not have many restrictions other than they need to go towards STD prevention and control in the United States. But certainly we, have a set number of resources that are appropriated to us. I would say that the expectation has been for years that most of our resources go out to state and local health departments. We traditionally have not had any remaining resources to put out towards community engagement investment. We invest about, out of our appropriation of $157 million, which is about 140 when it gets to our division. We basically have some grants called CARS, Community Approaches to Reducing STIs, that we have about $2 million a year that we're able to invest in, which usually is about 3 or 4 projects, and we get over 100 applications for those activities. So we know there's a greater need in the field of STI to be doing more work with community-based organizations and with communities. So we appreciate the resources we have, and we tend to be very nimble and flexible and innovative. Most of the time, we've not had a lot of resources to build a robust evidence base for STI prevention or a good business model for STI prevention. I can tell you that our health economists are still looking at data from the 80s at times when they're doing their economic modeling now, and I think that needs to be addressed. We really need to be using real-time current information to be able to develop our models and our business case as to why STD prevention is a good investment. So I would say that, any ways that people can think creatively about innovation, a term that's being used commonly now, is disruptors in our society. And also I think there's a lot of work being done in the area of machine learning and AI that at least public health is a little trying to understand what exactly data science is. We're having discussions about that at CDC. So I think we want to be forward-thinking in this report, to be taking sort of a scan of all these things that are happening in our site. There's a lot of things changing right now. We've got healthcare systems changing. We've got technology changing. We've got sexuality norms changing. We've got machine, learning, AI, and all this, data science that's changing the way we look at things. So I know I'm giving you a lot, but I'm trying to figure out how we can think in a more structural and systems way to address these problems, because I think the approaches that we've been using for the past, few decades obviously are not working for today. Okay. And then the last question really gets into the ability to monitor STIs and certainly how anemic our surveillance systems are compared to HIV. And I completely agree that we need to really build a better infrastructure of surveillance and monitoring in the United States, and would be very interested in hearing how we can better do that from other examples. I actually started my career at CDC not in STIs but in respiratory and special pathogens, and we had totally different models and had much better epidemiology data to sort of use for public health action. I hate to say it, we've been counting cases of chlamydia. I don't know why we're still counting cases of chlamydia. We now know there's over 1.7 million cases we count. So what are we doing with the information? And the case data that we get from CDC has very limited demographic information associated with it. So we still can't even stratify our cases by basic things like gay, bisexual, and men who have sex with men. We've been able to do it a little bit for syphilis. If you look at some of our graphs, there's little stars that said of the 70 states that report, or of the 35 states that report 70% of their syphilis with, behavior sex partner, and that's how we can generate some trends. So I think there's just a lot of sort of epidemiologic and social variables and social determinants of health that would be helpful to have more information on, so that we can really use our data to inform public health action and to measure impact of what we're doing and where we are in our nation. So those are my initial thoughts on your questions.
That's great. There were 3 questions that came in after we sent you the notes. One of them, I'll say first, is related to this issue of monitoring. What are the CDC and local health departments doing to standardize surveillance reporting, given the need to adjust for denominators of number of tests conducted, number of anatomic compartments sampled for site-specific testing, changes in sensitivity of tests, I might add number of STD clinics, and are there any impacts of program? What's the impact of programs that are implemented through the report that will need really solid and adjusted reporting? So, what is your thinking about how to adjust for these raw data by some of these factors, like number of tests conducted?
So I would say that there's a lot of important technology in informatics, and we've actually built an informatics division in our division of STD prevention at CDC. So, and I'm sort of learning the lingo, but we're actually working with FHIR, which is a new way to transmit data quickly. And we're also really focusing on the electronic health record. For years we've been counting cases based on lab reports, which again gives us very limited data. We don't know if a patient is pregnant. We don't get complete information on many of the limited variables that we're trying to collect. So I would say there's huge opportunity here that we really need to, I think, move forward in prioritizing implementation and program improvement, especially with our state and local health departments. One of the challenges that it's not a challenge, but if you don't know, the federal government has no laws that allow us to collect data from state and local health departments. So this is done in collaboration with CSTE, who actually defines the variables that are submitted to CDC through our traditional disease reporting system. Certainly CDC they actually have over 266 surveillance systems or something like that. So there's a lot of other ways you can do surveillance through Medicaid data, through other big data systems, and certainly our staff in the division are using those systems to see how we can better not only look at the social and epidemiologic variables associated with cases, but also look at outcomes. We have not been, except for congenital syphilis, we are not measuring neurosyphilis, ocular syphilis. We've got a very small project looking at disseminated gonococcal infection. So I think it's really important that we're doing a better job of sort of what is the health impact of these cases, these infections, and be monitoring those, and certainly having better information in the adverse outcomes would also better inform our economic models of the impact of STIs in society.
Just a quick follow-up to that. Do you think that some of your medical informatics and AI explorations can get a better handle on denominators, number of tests collected, number of clinics reporting, that sort of thing?
I mean, the data are out there. It's really a matter of manpower and resources to leverage this. And I think it's not just looking at, we collaborate with LabCorp, we collaborate with Quest, we're getting, and those are some of the largest laboratories in the country. We're trying to work with different electronic health records, but there's really important data that lives in clouds these days. Like right now, Google can detect, temperature changes to predict flu outbreaks faster than CDC can. So I think there are other innovations in this field of big data that and data sets that have to be looked at together. I mean, sort of the analogy that I look at about in a very simplistic way about data science, and please correct me for those of you who are in data science if I'm incorrect, but I look at it like we used to just talk about individual people. And then all of a sudden we realized we need to start looking at populations and denominators and networks and transmission dynamics. And then we used to talk about individual organisms. We just talk about chlamydia and gonorrhea and syphilis. And now we're talking about the microbiome because all these organisms are really smart and they're all interacting. And we need to start better understanding those interactions. And I think data science is sort of bringing all those big data systems together. They are interacting. And how can we leverage them, through their variety and their velocity and volume? Those are sort of the 3 V's of data science that I think about to really answer important questions that we previously have not been able to answer.
The other 2 questions, we assume that while HIV control is not the focus of the committee, the interface of HIV as an STI with other STIs is an important issue to address. Any guidance is appreciated.
Yeah, I think that if we're going to address the STI issues in the United States, you can't do that without thinking about the context of HIV prevention. Certainly with the great advancements in technology and tools that we have for HIV today, which are great, the HIV care system and the prevention system is a great opportunity to leverage more STD testing and more people that are accessing care that previously weren't. So I think that it's critical that HIV be seen as what can HIV do more of, to address the STI epidemic. For a long time, it was always about, well, what do STD, can STD people test for HIV? It was always a one-way street. And now I think it really needs to be a two-way street, the same way I feel about the healthcare system. What can the healthcare system do to address these epidemics? Because a lot of the most vulnerable patients, because of the erosion of the STD clinic infrastructure, are being seen in the private sector. And we know that a lot of cases of syphilis are not being correctly diagnosed. People are not being tested according to guidelines. So I think both for HIV and the healthcare system, it would be really important to look at what the evidence and science is around how these 2 systems can improve sort of the health of the nation around STIs.
That's terrific. And you also made the comment earlier about integrated concepts, and so that also answers that question. The final question is, what is the future of expedited partner treatment for chlamydia and other treatable STIs? What is CDC's interest in securing funding for this intervention?
Well, certainly we believe, like our screening interventions, these are underutilized services that I think need to be scaled up. We've got different models. We think it's that EPT is similar to, screening recommendations that come out from the U.S. Preventive Services Task Force that puts out prevention recommendations, and they are considering looking at EPT as a subset to the chlamydia and gonorrhea screening section. So this is an important, again, this is not something that we want for everyone. We want everyone to get into care, but it's a harm reduction strategy. We shouldn't have people sitting home exposed and likely to be infected with STIs and not have the opportunity to get rapid treatment. And then we can work on the linkage part to care. I would say the other change I see in the field of STIs is that for a long time we just kind of knew people had a lot of other, quote, co-occurring conditions, and we might have given them a little referral, like here's a little card, good luck, make an appointment yourself. I think the importance of linkage today in the field of STI is becoming critical, and we've got great models in HIV as to how to do that, because if you look at places that have good linkage for co-occurring conditions, those are people that are more likely to be virally suppressed.
Excellent. Thank you, Dr. Bolan. We have 5 more minutes. Dr. Hook?
Thanks for your comments, Gail. You mentioned in your comments this issue of integrated concepts, promoting health system partnerships, promoting partnerships with HIV providers, and the issues of public awareness. What's DSTDP doing to promote public awareness and knowledge regarding STIs, and who are the potential partners that DSTDP could work on to achieve that goal?
So I would say that most of what we do is sound the alarm, through social media and through media about the issues that we are seeing from a national perspective. We used to do some, formative research around social media campaigns, but the reality was that was great work, but we did not have the funds to do major social media in this country. So we've been trying to work with partners that do social media. Certainly we've always looked to ASHA as an important organization that has credible information and has been seen by citizens in this country as a place to go to for sexual health information. I think we have been working with our colleagues at CDC and DHAP to do a better job of synergizing our STD HIV messages so that when social media campaigns are being done by HIV, there will also be an opportunity to have some STD messages with those. I think this is an area we'd like to hear from the committee about innovative ways that we can educate the public more. I think that we do feel that I think for a long time there was also a focus on clinical providers, and I think we can do more to empower individuals to make healthy choices. So I think it is an area that we would love to see more robust partnerships. And again, maybe led by others. It doesn't always have to be CDC that works in this space, because I feel there's a lot of good expertise out there that we haven't tapped into.
Dr. Bolan, I have a question. So if I'm coming new to the issue of funding STI prevention, it just seems clear that compared to the burden, we grossly underinvest in STIs. I'm wondering if you have a theory. I'm not asking you about funding levels, but like in the past, we said at some points we were going to double the NIH budget, but because of the scope, we were talking billions. It took a few years. The Congress could reasonably just double your budget in 1 year.
Right.
But there isn't that urgency. I'm just wondering why. Is it that people don't know? Is it squeamishness about sex? I think American society does poorly with intractable problems, so they think this is intractable or they don't see a vision. Like, what's holding us back from having an urgency?
In my opinion, and I've worked in this field all my life because I feel like somebody's got to fight for it, is I think a lot of people, STIs are not high on their life priority scale. So they're not speaking out saying, this is really important, I want this for me. I think a lot of people with STIs secretly live in shame because there aren't the advocates, so that we don't have the same advocacy level that HIV has had for years. We've always had to try to ride the coattails of either women's reproductive health advocacy or HIV advocacy. And to be honest with you, what I'm also concerned about is we are losing STDI leaders in the field. So we need advocacy, but we also need leaders to work with the advocates. So that's another area that I think is where we're suffering. And I'm hopeful for our younger generations that I think are talking more openly and more concerned about these infections. And I'm hoping that this report can actually be the beginning to sort of change the sort of interest or concern about STIs in our nation.
Thank you. Dr. Sood.
Dr. Can you tell us a little bit more about how resource allocation decisions are made? So you said most of the resources are sent to local health departments. I'm curious, like, are they based on needs? Like, what role does cost effectiveness of different interventions play? How much do you direct local health departments to do intervention X versus Y?
So we do rigorous evaluation of the science and try to identify what are the most, cost-effective interventions that can be brought to scale in this country. Again, the resources we could do more. We were doing the best with the resources that we have. So about 75% of our budget goes out to state and local health departments and through a cooperative agreement. And we've been very strategic in recent years, recognizing the challenges that we face. That one, we actually do give out formula-based allocations. That was never done before until I came to CDC, and we found that there was a lot of programs that were out of whack from our formula. Our formula is different than, say, the TB formula or the HIV formula, where it's really just based on burden of infection, although I wish we could be like TB, because not only do they have it based on burden of TB infection, they also have a quality improvement measure. So if you get like all your TB cases, treated in the appropriate time period, you will get, extra resources for having a quality program. I would like to be able to reward program improvement. Everyone can improve, no matter where you start. So our formula is unique in that we felt it was unfair to just use case-based burden, because that could potentially reward the programs that were doing really well in screening, and the ones that had some more challenges who needed money more would be losing out. So we have a formula that's weighted by disease, and it basically 50% of the formula is for people of reproductive age in a given. It's a population-based formula, because in general, everyone becomes sexually active and everyone can be at risk of STI. And then the other 50% of the formula is based on burden. And we did do some states were concerned about rates versus numbers. So there's 80% that's based on numbers and 20% that is based on rates. And then we have a very specific strategies. We have 5 strategies we really want our states to work on. We recognize our states are very diverse. Our smaller states get $300,000. Larger states maybe get, 5-6 million. And as I always say about STD programs, when you've seen one STD program, you've seen one STD program. So we wanted to make sure there was flexibility, but we basically want them to make sure they have robust surveillance. We're available to provide technical assistance. We also have some other cooperative agreements we put out to help support us in that area. We want to make sure that we have good disease investigation and outbreak response. We want to make sure we're scaling up our known effective screening and treatment and other recommendations that are summarized in our treatment guidelines. That's sort of our sexual health guidance document, because we don't just put out STD guidance. We have HIV in there. We have HPV vaccination. We've got hepatitis, and we at least make the best effort to make sure our guidelines are harmonized with all other CDC guidelines, and we also work closely with medical organizations to try to ensure that our guidelines are harmonized with them, because we know when guidelines don't agree, that defaults to confusion at the provider level. And then we also want to make sure we've got some level of health education and policy work that's being done at state and local health departments. And then our last pillar is really using data for designing the most cost-effective, impactful program that can be scaled at your local level in your given context, and to really have good impact measures and value program improvement. So that's a quick overview of our program grant.
Great. We have 2 last questions. Dr. Rickmeyer.
Thank you. So, as a follow-up question to the last one, so traditionally, at least in the last number of grant cycles to the states, and about 75% goes to the states. Mm-hmm. So only 10% or so can be used for the direct provision of clinical STD services. And traditionally, I think the STD clinics have been sort of supported at the local level, and not so much at the and somewhat at the state level, but not at the federal level. Do you see a role for CDC in sort of the fraying public health infrastructure for STD clinical care?
So I would say that our main strategy for controlling STDs right now is, rapid detection and timely treatment. So any kind of clinical care is important, and we are very concerned about the erosion of the STD clinics. If I could have a wish, I truly believe, and I think that we have the business case to say, at least in urban areas where there are a lot of people in need of rapid STD detection and treatment, STD clinics are vital. And I'm talking about clinics that have welcoming environments for very diverse populations, provide comprehensive same-day diagnostic testing and treatment. And I actually think there's a cost-effective model that can prove to the healthcare system that this will improve the cost of your health care you're providing, the value of this service, and that I think STD clinics should be looked at, specialty clinics. We have some clinics that need to raise their services, but they should be looked at as equivalent to a cardiovascular surgeon. I mean, should primary care doctors be doing surgery? No, you refer to a cardiovascular surgeon who knows how to take care of the problem. So I actually feel STD clinics eventually should not be these mom and pop clinics that are run by health departments, that they should really be part of the healthcare system. And what we're trying to do right now is at least get clinics up to speed with electronic health records, billing, and delivering that quality of care that is cost effective, so that the healthcare system sees the value of how they fit into the health of their community. We're also trying to do something similar for DIS, and actually professionalizing disease investigators, making sure that there's a lot of different disease investigators out there. I know, and different opinions about what they do, but I think some of the really high quality investigators really are added value to the community. They find vulnerable populations that are not seeking care and assist them with linking them to care. And that's another population that if we professionalize them, there's core competencies and standards. There's also opportunity to have them be seen as part of the healthcare community and be reimbursed accordingly. But it kind of gets back to the history of both TB programs and STD programs, which were started in the 40s of this country. Traditionally, it was the responsibility of the locals, the state and local health departments, to serve their citizens and provide the clinical care. And then our federal dollars always went towards surveillance and more disease investigation activities. It would be great, to have more funding for STD clinics, and how to do that. That's one option, is to see how we could have it be part of the healthcare system. But I will say just a simple number that our health economists did at CDC. We just looked at, if we were going to screen all women who are either uninsured or underinsured for chlamydia in this country, and this estimate was done a number of years ago before the level of rates of disease that we have right now, that was $240 million. So, I think the challenge of trying to come up with some initiatives that would be, directly funding STI clinics, we've got to think creatively of how we can get to that. And I also think we need to start looking, because we're very concerned about what's happening in rural America, the role of telemedicine. And, could an STD specialty clinic, offer telemedicine services, including, I just saw what you can see through the otoscope through telemedicine. You can have someone listening to the heart sitting on the moon. I'm sure we could figure out ways to look at genitals and do pelvic exams through the technology today. So that's another area I think that needs some attention.
Thank you. Dr. Prado, last question.
Thank you, Dr. Bolan. You mentioned the great need for training the next generation of leaders. So I'm wondering if you can speak a little bit about areas of priority for training.
I think we need priority training in all areas. I think we need, leaders from the community. We need policy and decision maker leaders, those that are interested in, being in governmental positions. We need academic leaders. We need leaders at medical and nursing schools, because today still our medical students and nursing students do not leave many institutions with robust STD training and sexual health training. I think we spend a lot of time in our society on physical health, a little bit of time on mental health, and not much time on sexual health. So I think in all sectors of our society, I think there's a role for business. We really need leaders that say, this is an important health problem, and we really need to be addressing it for our young people and even some of our older folks.
Terrific, Dr. Bolan. Thank you very much. Okay. And obviously welcome you for the rest of the day insofar as your schedule permits.
I will be here. Thank you.
Good.